there's a sign here that says don't adjust the microphones, and until I did, it couldn't hear me. So, hi everybody. Here it is, can you believe it? It's the 10th day of October, and we are so pleased to have this wonderful group together. Thank you, Dr. Schatzel, for recommending this important topic for today of looking at atrial fibrillation as one risk factor for cardiovascular events that we don't pay enough attention to. So that is how we came by the wonderful happenstance of having Dr. O'Neill with us today. We'll be hearing from him in a few minutes. What many of us have been doing since 10:30 this morning is plowing through lots and lots of data with the California Department of Public Health. Thank you, Dr. Janet Bates and your team, for giving us detailed information about how in Sacramento, compared to the state, we have a higher incidence of heart attack and stroke at every age, across every ethnicity. We need everybody in the room to put your minds to why that is and help us to tackle it. What we do know from the information at the back of the packet that each of you have is that in the Integrated Healthcare Association publicly reported data that's on the Office of the Patient Advocate website, it's publicly available data. We have a long way to go on hypertension control, on blood sugar control, and although the data is not with us today, we also know that's the case for the use of statins. And with that, we know we have a big problem. We also know we have an amazing number of minds in the room to help us solve the problem. We have all the major health systems in the room here with us, lots of academics, health systems with us, and I want to ask your druthers. We typically don't go around the room and introduce ourselves because most of us come together on a regular basis now, and we prefer to spend our time thinking together. So how I've structured the agenda today is to have a lightning round like we did in July, where take a few seconds, maybe 5 to 10 words, and say, what do you think we need to do in Sacramento to make improvements to reduce this higher incidence of heart attack and stroke here? So with that, I'll ask Carla Pollack to circulate the microphone so we can hear everybody's thoughts on what the priorities are for Sacramento to reduce that preventable burden of heart attacks and strokes here. Dr. Terry Hill, Hill Physicians.
Terry Hill, Hill Physicians. The data this morning made me pay attention to smoking in asthma.
And Katie and Amanda, please take thorough notes on the answers.
Susan Ivey, UC Berkeley, same with Terry, more smoking cessation focus.
Focus on cardiovascular risk assessment for every patient over 40 and under, is it?
Every patient over 40?
Yes.
And if everyone would please speak up, and thank you for making the big trip, Victoria.
I'm Victoria Dupuy. I agree with Kristen and making a priority for early detection.
I'm Bill Simon. I'm the Exotic Family Medical Center. Identify risk factors and particularly ethnic and racial disparities.
And those are identified, get them on the ASAR, diuretic combo drugs, and statins, markedly reduces acute MS. Greg Bierker from HealthNet, and not only do we need to know about disparities, but also deliver culturally sensitive education.
Matt Walcott, I'm the Deputy Commander at David Grant Medical Center at Travis Air Force Base. But had a nice conversation this morning, and I like the idea of the bundle. We all know that there are certain evidence-based, and we're talking about the medicines, but the things that we could do as a bundle that go across various systems. Everybody's doing the same thing. but the bundle would be great.
And I'm just gonna break in to elaborate that the bundle that we were talking about this morning that we've applied heavily in San Diego that seems to have had an impact was created at Kaiser, and it's aspirin, lipid-lowering agent, and lisinopril. We saw some pretty fast action on that, and I'm glad to know that Health Net is embarked on pursuing that. So, where's the microphone now? Great.
Warren Barnes, UC Berkeley School of Public Health. In addition to the strategies and practices that we mentioned, we need to do what they did in San Diego. Establish a big area audacious goal, what Harvard Business School calls a BHAG, and go for it. The conversation has to be elevated higher than strategies and practices, not to leave strategies and practices aside, but we need to have a higher goal that absolutely energizes and motivates everybody, all hands on deck in every conceivable way.
Hi there, I'm Christine DeBellin-Wilson. I'm a nurse practitioner, but also working at Blue Shield. I think providing education through frontline staff in the healthcare system, especially for those who are at high risk for cardiovascular disease.
I'm Penny Higashi with Barrier Incline. My vote would be for earlier detection across multiple disease states and getting patients to care.
Hi, I'm Karen Sykes with Johnson & Johnson. As simplistic as it sounds, I lost 20 pounds and didn't think that I would still have high blood pressure. And when my doctor was monitoring me, my blood pressure was high for 6 straight weeks. And he said, guess what, my dear? Let's dispel that myth of losing weight equals lower high blood pressure. Let's get you treated. So I think there's a lot of education to do, even with relatively smart people like me.
Actually, we did have a Blue Shield medical director, Dr. Scott Flynn, present about that, I don't know, about a year ago.
I'm Joan Warblin, I'm a nurse, and I'm with the California Health Collaborative. My concern is getting this information down to the frontline staff, the nursing staff, the nurses, the RNs, the LVNs, the physician's assistants. I have yet to have my blood pressure taken correctly. After all the talk we've done here, and I really have zeroed in on that, and it just isn't done. And I'm willing to say not one person in that office would know what I was talking about. So we need, if we're going to make this successful, we need to get boots on the ground where the patient is, and that's the first line people taking care of them. Who don't get included in these sessions in educational meetings. They're sort of left on their own. They get hired, they have basic skills, that's it. So I think we need to look a little further down the food chain.
So Kristen Robinson from Kaiser was just telling us about a program that they have to do just that, to require the MAs to do certain things. Can you just say?
So first of all, they do audit the medical assistants to make sure they're doing it in checking the blood pressures in a standardized way. We also track the medical assistants, and not just in the primary care offices, but we're also doing this in subspecialty offices to make sure they're checking a second blood pressure when the first blood pressure is high, and booking a follow-up appointment with the medical assistant to recheck the blood pressure if the second blood pressure is high in 2 weeks.
And I know Mercy has embarked on a big re-education campaign for the frontline staff. So Joan, thank you for bringing that up.
I would just like to add that because several of our programs do not involve staffing that is in offices because we're community and county based and we're throughout the state. These are the people that are being lost in all of this update. How do we reach them? We need to know all the nurses that are going out involved in home visits and programs, following up on discharges and all of that. Everyone is getting the same message, not just the ones that are working in the brick and mortar, because there are a lot of staff out there that are just, dispersed to the wind. They're all over the state.
It'd be very interesting to see if we could have required continuing medical education on this with testing for that frontline staff. I don't know how to go about that, but
Just giving them, they're not getting the basic information to begin with.
cardiology clinic at UC Davis, it was our standard that patients would sit for 10 minutes before their blood pressure was checked. We also checked on both arms, and that was pretty standard with all of our patients. I don't think that gets done in all of the clinics, and it would be great if it was, because that gives you so much valuable information. I want to echo the sentiments of just patient education, getting them connected, screening early, but then following up on that screening. If you start them on any treatment, following up with them to see if there's changes. But mostly, I talk to a lot of patients who have strokes and heart attacks, and there were things that were identified early, but they didn't know what different medications were for, or they didn't realize if they stopped smoking or did different things that it would affect their health. So I really think that patient engagement is probably going to be the most crucial factor.
Olivia Casiri, Public Health Officer. I already had the discussion about this, and for me, I think the two most important things, one is population health for the health systems in Sacramento, and then the other is also developing a health information exchange system so that information is more easily and readily available to the clinician as well as to the folks at the administrative level who can make system changes.
Dave Herbert, Center Independent Physicians. I think one of our challenges, in addition to all the ones we've heard, is to get patients who have risk factors but who are transitioning into increasingly high deductible health plans motivated to return to the care that they need.
Steve Heath, Capital Health Network. That rattling sound you heard was me nodding my head as everybody else talked, especially the HIE. Our members at community clinics really need a way to track and manage the population they're responsible for, especially as we get towards Medi-Cal payment reform and the responsibility to manage that process.
Alan Schatzel with the Mercy Medical Group and the New York Neurological Institute. I've heard a lot of really important things about prevention, prior prevention. It really comes down to education and information and trying to get people engaged, not just patients, because patients, we assume they've had access to us, but people as far as the community as a whole. I do a lot of stroke care in our hospitals, and if I boiled it down to two types of patients, one patient who has strokes are ones who don't have any medical history, but then now they have a stroke, and that's because they haven't had access to the system, they haven't been screened, and they haven't been put on the right medicines. The second patient is one who has access to the system, has 5 or 10 diagnoses, but are not taking their medications, or if someone had said they don't understand what the medicines are for, they didn't know how important it was, and also they continue to smoke. So getting education out there, engaging the community, I think being innovative in how we do that is really important.
Chris Wood from Community Health. Agree with the community education and people like that with symptoms.
If you could speak up, please.
Joyce Higley, Dignity Health as well, from the Heart and Vascular Institute. So really ditto both what these gentlemen say. You know, one of the things I think personally when I sometimes have to think about this is the way I use the system. So I'm part of the group that has access. But for me, my experience most of the time, even though I know I have risk factors, is that my access is about urgent care, even though I have an appointment. And they're still asking me why I'm there, what's my key chief complaint today, that type of thing. I see here some heads nodding. So I think that's an opportunity from an education standpoint is to teach patients about their access opportunities, but then even when you have access, how to use that time with your physician, maybe, and not just go when you've got aches, pains, or when you're feeling sick.
Hi, Janet Bates, California Department of Public Health, and certainly agree with what's been said here. What I have not heard mentioned yet is the epidemic of prediabetes that we're experiencing in the state and across the country. There's evidence-based treatment for that, so also include in all of this identification of patients who are pre-diabetic and take steps to prevent them from progressing to diabetes, which will reduce their risk for cardiovascular disease as well.
Hi, I'm Elizabeth Digmont with the California Department of Public Health, and like we talked about in the data discussion this morning, more health education for smoking cessation.
And hi, I'm Brendan Darcy, also from the Department of Public Health. From a public health perspective, we focus on prevention activities, so better smoking cessation education and physical activity incentives.
I wonder, Dr. Schatzel, could you just say a smidgen more about those patients that have not interacted with the system before they come in with their stroke? How can we be screening them? How can we be catching them? Is it that we've got that higher incidence of hypertension that the Department of Public Health is?
Yeah, I'm sorry I wasn't at the data session, so I haven't seen that information, but there is a disparity in people having access to appropriate medical services. And I think, as Joyce said, having access to the appropriate medical services, but not being informed or educated enough to ask the right questions when you're in front of a provider who has all of the knowledge to help in prevention is a gap, is a limitation. So if we had innovative ways to educate, inform, engage all community members, no matter what group they belong to, or whether they have access to the system. Some people don't have insurance and don't have access, but if we had some way of helping them understand what the potential risks are for heart disease, stroke, then I think we could do better. I know we could do better. Is that enough? Shall I go on?
Well, I do believe that we might be able to engage some of our touch points with patients a little bit better. So as the daughter and granddaughter of women who died early from strokes, I can say that people go into healthcare settings for a variety of reasons, including pharmacies, and they don't have, those touch points are not, I think, utilized properly, like Joyce was saying from Mercy Heart and Vascular. So I would just urge us all to think about where we meet with patients, how do we do like Kaiser does and say, regardless of chief complaint, we're going to take that blood pressure. And you know what? Regardless of whether you commit to doing lifestyle changes, we're going to start you on your meds because that's where the research tells us to go. So I think that together we can solve this, but it's a long, hard slog. And thank you, Dr. Revelo and Dr. Mary Firmison in particular for being the ones to keep pushing that rock up the hill with us.
Yeah, well, thank you, and really it's the community that really we're focused on and trying to ensure that these messages that we continue to bring forward to you on a monthly basis are messages that resonate with you. And so it's really important, and this exercise that we just did is really important for us to get a sense of where you are as members of the community. I have to say for me, because to answer that question, I want to echo both Olivia and as well as Steve's comment about health information exchange, and one of the issues around populations that really do have some access, but maybe not perhaps the greatest access, and being able to get that information to all of us who will eventually care for those individuals when they become just people in the community and now become patients, to be able to provide the most appropriate interventions based on knowing what their risk factors are and knowing where they are. So that piece of getting the clinical information to each of us at the right time, I believe, is very critical. And I was just talking to our speaker, Dr. O'Neill, and he mentioned that that's one of the challenges that he feels is happening within our system, is not being able to access information in a timely fashion to be able to care for individuals when they have a time of need. So it's a big issue. We're working on it, by the way. There is a new set of, or because of the work that's being done here in Right Care, we've been focusing on bringing up this discussion, not because we're going to solve it, but because we are part of the community that is going to help light the fire to bring that health information exchange up. And by the way, just as I mentioned, there are people who have been invited to a meeting November 7th to continue this discussion. Unfortunately, I have to say that that meeting is going to need to be postponed for a while because of some new issues that have come up. So Steve and Olivia and several other people that were coming to this November meeting, you'll be hearing a little bit more about that, postponing that meeting. So I apologize to you that the November 7th meeting will not be happening, but we're focused on this piece of activity that will eventually help elevate quality improvement in the Sacramento region. So I now have the privilege of introducing our speaker, Dr. Gerald O'Neill, who comes to us by way of Dublin, Ireland. Is it Dublin or Ireland? Yeah, and who was trained there in internal medicine and pediatrics, and then moved to God's country, Houston. Actually, I'm from San Antonio, so I have to take it in. Houston, trained in Houston, and then we were fortunate enough to bring him here to Sacramento, and he's been here for 20 years. And as many of you know, he's now in Mercy Medical Group and the director of the electrophysiology services, and has done a lot of work and a lot of publication on the current topic that he's going to help us understand further about, and that's atrial fibrillation, which is something that doesn't come up as often but should, and the impact atrial fibrillation has on cardiovascular complications and stroke. So, Dr. O'Neill.
Well, good afternoon, everybody. Thank you for this kind invitation to attend and speak with you. I have to say I was very intrigued by the conversation going around the room, and I was chomping at the bit to get in on a couple of things. In particular, I was intrigued by David's comment about the difficulties we have with patients with high deductible plans. And it reminded me of something I had learned about the healthcare system in France, where women having antenatal care are actually paid to go to those antenatal visits rather than having to pay. And I'm thinking, you know, you have to invest to succeed. And some of the treatments I will be talking today are no doubt expensive, but far more expensive is the consequence of not treating. Okay, so my brief today is to talk about atrial fibrillation and review some of our therapeutic options at present. And so here's what I want to talk about. I understand it's a diversified audience, so if you forgive me, I'll take a few minutes at the beginning to kind of go over some basics here. So I want to talk about the nature of atrial fibrillation, what causes it, and what the consequences are. And the principal consequence we worry about, quite honestly, is stroke. That's always foremost in my mind when I'm seeing a patient with atrial fibrillation. I want to talk about some of the new developments that we have that reduce that risk of stroke. And I'll talk about some of the preventative health strategies that we can use to decrease the incidence of atrial fibrillation. I think that fits in nicely with the mission of this organization. And we'll review these treatment options. So I have to say, when I was back in cardiology school in Houston, atrial fibrillation was kind of a poor sister. Really, there wasn't much thought given to it because there wasn't much that we could do about it, or we felt there wasn't much we could do about it. But a lot has changed. So what is it? Why do we care? What causes it? And what can we do about it? Well, first of all, on the left of the screen here, you see a diagram that represents the normal electrical activity of the heart. And under normal circumstances, the electrical signal progresses from the top chambers, the atrium, to the ventricle. And let's see if we have a, yes, progresses evenly. So you have the same number of contractions in the atrium followed by an equal number of contractions in the ventricle. And when we look at an EKG, we see this manifested by a small bump here, which we call the P wave. That represents the sum of electrical activity in the atrium. And then this large deflection that follows represents the sum of electrical activity in the ventricle. This is the way it should be. When you have atrial fibrillation, chaos ensues, and the heart is discharging in a random fashion, oftentimes 400 to 600 beats a minute in the atrium. So if you were to open a chest and look at a patient who's having atrial fibrillation, you literally see the heart quivering. We call it a bag of worms. And the way we recognize it medically, the simple way is feel the pulse. It'll be irregular, and sometimes we can treat our patients to do, or teach our patients how to do that. But the EKG then shows this chaotic pattern with very irregular beats, as you can see. And in fact, this irregularity is exploited in some of the diagnostic technology I'm going to talk about. So that's how we diagnose it. So the significance, well, it is the most common sustained cardiac arrhythmia, and at least 5 million people in the United States are currently affected. It's anticipated by 2050 we'll have 12 million people with this diagnosis. It's mainly a disease of the elderly, but I see it in all age groups, admittedly much more commonly in the elderly. It's rare to see it in people in their teens, very rare, but anytime after 20 we can see some atrial fibrillation. It mainly affects men, and the lifetime risk of developing atrial fibrillation for adults who reach 40 years of age, and I look around here and most of us have, is 1 in 4. It is probably the most single most identifiable cause of stroke in the elderly population. Having a diagnosis of atrial fibrillation increases your risk of stroke 5-fold. This is from the Framingham study. 15 to 20% of the strokes that occur in the US are ultimately attributable to atrial fibrillation. And very importantly, if you do develop a stroke in the context of atrial fibrillation, the outcomes tend to be worse. 1/3 of people who have a stroke in atrial fibrillation will be dead in a month. 1/2 will be dead in a year. If you survive, you're more likely to be significantly disabled. The stroke risk is there whether you feel the atrial fibrillation or not. I will go in presently to some of the other risk factors we use in calculating the risk for a stroke. It's a very expensive diagnosis for society because it is the leading cause of hospitalization for arrhythmia diagnosis, as you can see from this slide. And here's just the notion and the data and the projections for the future incidence of atrial fibrillation we will have. Again, just to remind us that the principal concern is stroke. This is a CT picture and the Eros point densities that we don't like to see. It's not just stroke, however. The other consequences of atrial fibrillation, the consequences of the heart beating erratically, include fairly non-specific symptoms such as general tiredness or shortness of breath. People may be aware of the irregular heart action, something we call palpitations. And if atrial fibrillation persists and is associated with very rapid rates, it can actually trigger congestive heart failure. Why do strokes happen? Well, we think that clots develop inside the heart because of stasis, because of that quivering motion. The heart is not projecting the blood forward. Clots happen in a situation where the blood doesn't move effectively. And when the clots leave the heart, the first arteries they encounter are the ones going to the brain. That's why it may cause stroke, but you may be lucky enough, or not lucky enough, for the little plug to bypass those branches and go down to a distal part of the circulation and cause embolism. It can lead to occlusion of the blood vessel anywhere in the body. So you can present with an ischemic limb or an ischemic bowel, and all of these have major consequences. So when we talk about treatment and prevention and protection, we're talking about mitigating the risk of both stroke and systemic embolism. So what causes it? Well, the causes are manifold and legion. There's only one really true reversible cause, and that is an overactive thyroid gland. This situation applies about 1% of the time. Notably, George Bush the first, or 41st, I forget what the number was, had that diagnosis in the White House. So his hyperthyroidism was treated, his atrial fibrillation went away. But it's infrequent that we are so lucky. Listed on this slide are multiple other associations with atrial fibrillation. There are genetic issues. Valvular heart disease is a significant factor in the evolution of atrial fibrillation. And atrial fibrillation can in and of itself cause valvular disease. What happens is that when you have that irregular, chaotic motion in the atrium distends, the ring around the mitral valve gets widened, and then the valve becomes incompetent. However, if you can